your presentation.
All right. Good afternoon. My name is Laura Hesse, and this presentation covers SDX training related to the equipment used at Penn Medicine, how to properly train patients, the sites that it is used for here, how to assist patients who are having difficulty using the equipment. During the presentation, Alaina and I will discuss age-related issues and the problems that can occur during the procedure. The process will be covered from start to finish, including how to achieve the desired results and how to apply them. So this slide demonstrates the SDX and all of its components. The device labeled 1 on the screen is the SDX module. It comes with reinforced cable connections, and the connections to the video glasses are integrated for an improved and more efficient workflow, which helps a lot when moving around to different machines and from sim to the treatment room. The device labeled 2 are the video glasses, and they directly connect the SDX module, which also simplifies the use. The device labeled 3 is the trolley, and it features a combined power and data cable to help improve the workflow efficiency between, like I said, multiple simulation and treatment rooms. At Penn Medicine, we have computer monitors in every room that have the SDX software and can connect to the system. This slide also shows the SDX and its components. The first picture shows what the bacterial filter looks like. It creates a protective barrier between the patient and the breathing tube, also known as the honeycomb, to help avoid any contaminants to the other parts, such as virus and bacteria. The bacterial filter is used one time and discarded after use. The second picture shows what the mouthpiece looks like. When the patient has it in their mouth, their lips will be tightly sealed around it, and that's slightly sealed around that part. The patient's teeth can slightly rest on the squares. They don't have to like bite down on them. The mouthpiece is used, of course, one time and discarded after use. The final picture, the third picture, is what the bacterial filter and the mouthpiece look like when they are connected. So this is the SDX goggles. This slide shows what the glasses look like. It is a sleek design with a black rubber piece on it that helps shield the eyes from other distractions in the room that might occur in the room. At Penn Medicine, we clean the outer surface of the goggles with hydrogen peroxide wipes. But you have to use caution when wiping the lenses of the goggles. The lenses of the video goggles are recovered by plastic and can be easily scratched if it is wiped with an abrasive products. We use a buddy cloth or a soft microfiber cloth with a little bit of saline solution and wipe them in a slow circular motion until the lenses are clean. The IFU is available from the vendor. If you want to look at it, it's always updated. So the silver component is called the honeycomb, and filtered air will pass through it in both inspiration and expiration. It is in the breathing tube where the bacterial filter is connected. Usually the only time it is removed is for cleaning and when it needs to be cleaned. So this button will eject the honeycomb out of the sensor. And it's supposed to be flush on it and not look like this, not flush. So Penn Medicine uses a SDX OPA for about 10 hours. It's sterilized in. Okay. This slide shows the SDX module with the arm, sensor, bacterial filter, and mouthpiece as it is connected. The arm is flexible, so you can reposition it for patient comfort and clearance. So this part kind of flexes around. The nose clip can be a one-time use or can be used for the patient's entire treatment. But if you use it for the patient's entire treatment, it has to be properly stored in a basin or a small baggie, labeled with the patient's name and date of birth, and stored with the other devices that the patient may have. So this slide shows the SDX cart and the device itself. At Penn Medicine, we clean the external parts with hydrogen peroxide wipes. The cleaning can also be done with medical grade alcohol-free or low alcohol wipes. The two products are Bactinial and SDX. Mentioned on this slide were tested and recommended by DYN'R for the decontamination of the honeycomb. You can also look up the IFU that's available for the vendor. So daily warm up. When you open the SDX system, the home page will tell you if the calibration has not been done. And it's right here, usually. To perform the daily QA, you have to click on the syringe icon shown right here. The device used is the daily QA syringe, and it is inserted into the honeycomb. The QA syringe allows for easy calibration. So you have to ensure that all of the power outlets and network connections are plugged in. Next, you will need to flip the switch on the back of the cart and turn it on to use it. Once the switch is flipped to the position, a light will turn green and on the actual cart. Once it is on, the blue light will appear on the back of the SDX box as pictured. So for daily calibration in therapy, you have to wait 5 minutes. In monthly calibration for the physics, you wait 20. Connect the syringe to the honeycomb and press play. The handle on the syringe should be moved out as soon as the syringe icon appears and it starts moving to the left. The first wave will not display because the system is still calculating. Make sure that the 3 waves are performed evenly and do not go too fast, or it'll give you like an error. Create a flat line at the top and bottom of each wave by briefly pausing, and leave the handle in the syringe after the wave is complete to allow the system to calculate. So that's what it looks like on the screen. Yeah. So both these have to be green, these both lines up here to start your calibration.
So for training and coaching during the session, you're going to first enter the patient's information. Once you enter that information, there'll be little check boxes that appear next to it. So you'll check them all off. You'll click save. Then you'll go to the first phase, which is preparing. You're going to show the patient all the equipment and explain each piece and review the whole process of what they can expect during this. You're going to place the patient in the treatment position with only the nose clip and the mouthpiece first, because first you just want to get their breathing You're going to press play and have the patient breathe normally. When the system's ready for the first measurement, it will appear at the bottom, ready for measurement. Usually it's about 3 normal breaths of the patient going into the gray stability zone at the bottom. If the patient's breathing peaks go above or below that bar, you want to make sure that their lips are tightly sealed around the mouthpiece. Sometimes this is an indicator that air is leaking out somewhere. So you're going to instruct the patient to breathe normal. And then once you're ready, they're going to take that nice deep breath in. They're going to fill their lungs as much as you can, and then they're going to hold their breath. You want to make sure that they can fill their lungs as much as they can because this tests their max breath hold. Once they hold for a couple seconds, they can breathe normal, and you're going to click stop on the respiratory data to calculate the respiratory data capacity. You're going to repeat this process a few times. Sometimes their ranges can be not close together, so if you need to do it more, that's okay. You want to make sure that these levels that you're receiving are within close range. For example, you would want 1.12, 1.2, 1.4. You wouldn't want to get a level that's out of range, like a 1.7. You would have them do another cycle. If you find that they start to get a deeper inhale and the range is higher, you want to go off of those 3 highest ranges. This calculates their biggest breath hold and will take most of their lung and stabilize everything internally more. So once you determine the patient's gating level, you're going to take the average of those 3 max breath holds. Here at Penn, we multiply that average depending on the site. So if it's a breast patient, those patients are going to get multiplied by 85%. For every other site, that percentage is 75%. This will be the patient's gating level. If the patient was holding at 100% the whole time, every time, they would get tired and fatigued and wouldn't be able to use the device. So that's why we kind of have them use only 75 to 85% of that. You're going to record this breath hold level in the breath hold level box. So you're going to enter that number right here. And the gap level and the stability gap are standard constant values from the vendor. So you're never going to change these. So they'll always be 0.1 and 0.14. So that just changes. This is the stability zone, this gray bar that I was talking about. So you want to make sure the patient kind of breathes in that gray bar. If they went below it, that's when the system doesn't count that as a breath. And then if the patient goes above the green bar or below the green bar, it's not going to register them as holding their breath. So you want to make sure that they can get into that green bar. So once you establish that breath hold level, that's what these horizontal white lines are. And that becomes that solid green bar. So that's their gating level. So once you establish that level, you're going to give the patient the goggles and make sure that they can verify everything on the screen. You want to explain to them everything that they say. If the patient does wear glasses on a regular basis, they can use glasses underneath the goggles or not use them. It's honestly their preference. The patient doesn't ever have to read anything on the screen. It's just they have to be able to see the colors and the lines. That's it. So you want to explain to them that the lines that are going up and down is them breathing normal, and those lines that were going straight up, that was them taking their deep breath in, and the horizontal line is them holding their breath. I can go back to show you. So these lines going up and down is them breathing normal, and then that line going straight up, that's them holding their breath or taking that deep breath in, and this horizontal line is them holding their breath, and then this going down is them breathing normal. So once you want to also verify that the patient isn't colorblind. That has happened to us. If that is the case, you are able to change the colors. You're going to click the play button to continue, and once the patient receives that green light, you're going to have them take that controlled deep breath up into the horizontal lines, into that solid green bar, and you're going to see if they can hold for 30 seconds. If the patient's ever not able to hold for 30 seconds, they can go ahead and just breathe normal. You kind of just want to base it off of their comfort level at first. But then if they can hold to that 30, you're going to give them let them breathe normal, talk to them, see how they feel about the 30 seconds. You are able to drop them down to 25 seconds if they feel like 30 seconds is too much. Sometimes patients get a little overwhelmed and they feel that 30 seconds is too much, even though they were able to do it. I try to encourage them that once they are using the system more, they actually get better at it and it does get easier for them. If the patient is having issues getting up into the green bar, you want to make sure that they're keeping that tight seal around the mouthpiece. You also want to make sure that the nose clip isn't slipping off their nose, because if air is escaping, they're not going to be able to reach that calculated gating level. You're not going to want to accept a breath hold less than 25 seconds, mostly because it takes at least 22 seconds typically to get through the CAT scan. And if they're not able to hold for that 25 seconds, they're going to have to do more breath holds on treatment. It's going to cause their treatment to be a lot longer, and the patient does tend to get fatigued. If the patient isn't able to pass SDX, you're going to call that doctor and just let them know that they weren't able to tolerate it. And then you always want to document that you did try SDX and that the patient failed it ultimately. If you do want to adjust the timer for, say, the person, because it defaults to 30 seconds of holding breath. So if they're only able to hold for that 25 seconds, you can go into settings and click timer and you can adjust it there. So once you figure out, you establish their gating level and that they can hold for the 25 to 30 seconds, you're going to exit the preparation stage and you're going to save the defined levels. So once you click the home button, this box will pop up and you want to click save. And this will store their information. And then, so once you save that, you're going to be brought back to the main screen and you're going to click on the imaging tab. So the imaging tab is where you're going to practice with the SDX with them and get them super comfortable with it. It is very similar to the preparation stage. There really is no difference. You want to make sure that you explain all the visual cues that they will see on the screen. This is important during the training because you want to stress to the patient that when they come back for treatment, they're going to look for these visual cues, and that's how they're going to know when to hold their breath and when to breathe normal. There isn't going to be a therapist in the room telling them when to do it. I think patients get comfortable feeling that you're right there, like as a crutch, but you want them to know that you are just outside the room, so they'll have to look for those cues. All right, so you're going to have the patient breathe normal. So this is in the imaging stage. So they'll breathe normal. And once they get those 3 normal breaths in that stability zone, they're going to get this green bar will come up, or square. You're going to click that and it will give them the green light. And when they get the green light, also that green bar is going to appear. So these are their 2 visual cues of when to hold their breath. So then they'll take that normal breath up into that green bar and they're going to hold. While they're holding their breath and in the middle of that green bar, this light is going to turn orange. So this signifies that the patient is holding their breath, the timer has started, and then that the radiation will be on. So you want to make sure that they're kind of holding their breath in this middle green bar in a solid line. If you see that the line can get squiggly, sometimes that means that they're kind of letting air in and out of their lungs, which you don't want to happen. So when you're ready for the patient to breathe normal, you're going to hit that middle button again, and that turns on the red light, and it also makes the green bar disappear. So that'll be those 2 visual cues for them to breathe normal again. Sometimes I do find that the lights at the top are hard to see based off of the angle of the goggles. So I do like to tell patients that the green bar is a really easy way to tell when the therapists are ready for you to hold your breath and when they're ready for them to breathe normal again. It's also important to tell them that just because they have the green bar doesn't mean that they need to rush to get up into that green bar. They can take another normal breath if they need to before they inhale and hold their breath. After the patient feels comfortable with the system and the training is complete, you're going to begin the simulation. Coaching is required for all SDX patients prior to simulation. You're going to record that gating level. For us, for Penn Medicine, we record that gating level in the simulation encounter in ARIA. When the simulation is complete, you're going to click that home button at the top again, and it's going to, before you exit, ask you if you want to save, and then it's going to bring you to this, so you'll only have the treatment tab open. This is important because it makes sure that all of the patient's information is saved. Sometimes if you don't click out of imaging and you unplug the computer, it cannot save their information. Some tips and tricks while training. Sometimes the goggles can slide on their face, or it's at a hard angle for them to be able to see the screen. So you can tape the goggles to the bacteria filter, and this holds them in place better. The nose clip sometimes will slide off a patient's nose. Sometimes if you just take a little alcohol pad to wipe their nose, or you take a little piece of gauze and put it in between the nose clip and their nose, that also holds it in place. You want to make sure that the nose clip's on really tight so that they aren't able to breathe out of their nose. You want all of their breathing in and out through the mouthpiece and the filter. The patient might not have a tight seal around the mouthpiece at all times. That was giving that squiggly line I was talking about. So you want to have them purse their lips around the mouthpiece, and this helps to remind them to keep that tight seal. And you just want to tell the patient too, when they get that green bar, they want to take a controlled breath up into the green. Sometimes patients will see that green bar and they kind of panic and they do a deep breath in very quickly, and that causes an error and says that the flow is too high for the SDX. So this is where you would change the colors. If the patient was colorblind or they were having issues seeing the red and green, you just go to the 3 lines and go to display parameters, and then you're going to click the red bar, and then it'll come up with all the options of the different colors, and same with the green. You can do this while the patient's wearing the goggles. This is pretty helpful because then they can tell you what they can truly see the best. Disease sites that we use for SDX. We do a lot of lung SBRTs, livers, breast lymphomas, bile ducts, retroperitoneums, a lot of things that are very close to the diaphragm that tend to move a lot, things in the lung. The breast is important because it gets the lung and the heart out of the way and less lung dose. The various types of immobilization devices that you can use with SDX. You can use the breastboard. So the SDX just goes right above the breastboard, and it the gooseneck goes around. This kind of also helps to get the patient's chin out of the way. We can use the regular wing board. You can use backlock bags. We do a lot of our full body SBRT bags with the SDX, and 5-point masks for the lymphomas.
So challenges and factors to consider when selecting patients. Age factors is a huge part. Adolescents tend to have an easier time learning it. They think it's fun. It's like a video game. Patients' language barriers. There might be a language barrier between you and the patient. If the patient has a lung or breathing disorder at rest, this should be also considered because they probably can't do it. A patient's anxiety level and willingness to actually use the device. Some patients might be good at it, but they might not want that added stressor during treatment, or they might not want to continue to use it for every treatment.
For CT simulation with SDX, this will be the flow that we follow for non-contrast scans for proton or photon scans. So first you're going to perform that breath hold scan, and you're going to mark the isocenter per the MD request. You'll mark and tattoo the patient. You're going to perform a free breathing scan as well. And some of our doctors do still request a 4D scan if the patient passes SDX, so you'll do the 4D scan as well. That free breathing scan will just get imported into Eclipse, and you're going to set the isocenter using the same X, Y, and Z coordinates from the breath hold scan. After the patient is completed, this is just to reiterate that you want to make sure that you click home and save on the SDX computer. This makes treatment the only option when the patient comes back for when they come back for their treatments on a daily basis. You do want to document in the SDX that the SDX device was used in the setup note, and you want to also include pictures of the patient in the patient position and with the SDX still connected to them, just in case there ever is any questions when they come back for treatment. And you want to enter your SDX coaching results. You're going to make sure you put that breath hold value in and the duration that they were able to hold their breath for. So this next slide is for contrast scans with proton and photon. It is very similar to non-contrast scan. You perform that breath hold scan first, and you're going to mark the isocenter, and then you're going to mark and tattoo the patient. You'll still perform that free breathing scan, and at the MD request, you're going to still perform that 4D scan. So the last scan that you do is you're going to do a contrast scan, and the contrast scan is going to be with a voluntary breath hold. So you want to make sure that you take out all of the SDX parts from them. You don't want the mouthpiece in or the nose clip on, just in case the patient did have a reaction to the contrast. You want to make sure that they're able to call out to you or get your attention. So if they had the SDX mouthpiece in and everything, it would be hard for them to get your attention. You're going to import that free breathing and the voluntary contrast scan into Eclipse, setting the isocenter with those same coordinates from the breath hold scan, the X, Y, and Z coordinates. After the patient is completed, you want to make sure that you click home and save on the SDX computer to make sure all of their information gets saved into the software so that nothing gets lost. You do want to document the device just like before and include any photos that would be helpful.
So the daily treatment with SDX, you of course want to first set up the treatment table. We use setup simulation notes in our documents, and like Alaina said, this includes all of the devices used at the time of sim, pictures of the devices, where they were indexed and put on the table, the SDX level, and the time that the patient could hold their breath for. It's very important to add all that into that. Then you will attach the SDX holder to the head or at the top of the table and place the SDX trolley close to the couch, but make sure it doesn't get hit or anything. You always avoid stretching wires, and you have to verify the wire placement to make sure the gantry clears and the imagers before you leave the room. So check the gantry clearance of the SDX unit and wires. And you make sure the network cable and power cord are plugged in and everything works. And you, of course, want to do a dry run with the patient before you leave the room. So like I said before, you want to acclimate the patient with the SDX components. Like show them the mouthpiece and how to put it in again, and run through a few breath hold cycles before leaving the room. Verify the gating level in the patient's file matches the value in the therapist's SDX coaching results in the encounter and the gating alert. If there's a shift and it is necessary, we usually remark the patient's new treatment isocenter while he or she is free breathing. Image the patient under breath hold according to the physician's treatment instructions. Our physicians put in treatment instructions that include type of imaging, the target, and the target to align to. Image the patient, of course, under breath hold. Ensure that the patient's breathing track is within the breath hold zone prior to the delivery of the imaging beams. You always want to make sure their breath hold is in the green bar. I always tell them to go up slowly and hold it in the middle of the green bar, and that the timer has started. Treat the patient under breath hold start the imaging trace and the beam on when the breath hold zone has reached the timer and it has started. Pause the beam if the patient's breathing trace deviates outside the breath hold zone, and allow adequate time in between breath hold cycles for the patient to catch their breath and get ready for the next. You don't want them out of breath. And archive the study by, of course, clicking the home button and exiting the program.
So here at Penn, we have proton and photon machines. We do utilize SDX for both of those modalities. For protons, it does tend to add a little extra treatment time to the patient's table time. The treatment fields often have a high MU, which can make it more challenging for the patient to hold their breath through the entire beam delivery. So this results into you having to break up the beam into several different multiple breath hold sessions. Usually most patients do fine with this, but this is where it comes into play that you don't want the patient to only be able to hold their breath for, say, 20 seconds. You want to at least have them hold that 25 because they can get through much longer. And then for photon, the beam delivery time is a lot shorter. The only time I would say that it tends to be a little bit longer is when you cone beam. Usually the patient has to do 2 breath hold sessions to get through that CBCT.
So SDX maintenance. You want to clean the goggles with the appropriate lens cleaner because, like I said, they scratch easily because of the plastic coating on them. Daily single-use items include mouthpiece filter and nose clip if you want it to be. You don't want to wrap the cords tightly around the trolley when storing it. So it could add to a problem like a cord coming loose or something. The honeycomb sterilization will occurs monthly or every 500 cycles, whichever comes first. So, like I said before, to take out the honeycomb, you need to engage the silver button on the side. We document the SDX cleaning in like a log. When reinserting the honeycomb, you have to line up the notch and verify that the stem is flush with the black gooseneck. When the honeycomb is reinserted, the daily QA should be performed. If the daily QA fails, the full monthly QA has to be done. After opening up the SDX software, allow the stabilization counter to run for the full 20 minutes for the monthly QA and wait for both the lines shown on the screen to be green. If you click those 3 bars in the upper left-hand corner, you would select the calibration under the drop-down box. Then you perform the 3 waves with the syringe. Use the same method as the daily warm-up procedure. Select stop once you are complete, and it'll automatically revert back to the daily QA page, which after you've performed a monthly, you'll perform the daily QA. So you always have to ensure that there are no loose cables to the SDX box, the SDX trolley, and the wall outlets. And like I said, the back of the SDX module, the light should be green when it's turned on the cart. And then the module will have like a blue light. And these are the connections you should make sure that it's connected to. And this page will tell you if something's wrong or not connected underneath this little suitcase type thing. So computer connections are cords, the KVM extender, and you have to verify the computer display settings, or the resolution is usually 1024 times 768, the refresh rate, and the display. are correct. In the event that the SDX is no longer operational, we notify physics, therapy manager, and the physician of what's going on and what the issue is and what we can't get to work. We check all the wires and settings, of course. If the goggles are not working, though, we first receive approval from the doctors, and then the therapist can verbally instruct the patient and talk them through the session. The therapist will be able to view the SDX treatment session on the computer to see the breathing phases, and the patient will have the mouthpiece and nose clip, but no goggles. We always add in documentation into the patient's chart saying this was done and what happened. So SDX troubleshooting. So to avoid any leak and unwanted unplugging, ensure good measurements, please check that the 2 silicone sleeves, which are pictured, of the tubings are straight and completely synced into the barb connectors. The tubings are usually 2/3 inserted in the silicone sleeve. The red sleeve is plugged onto the right barb connector. So down at the bottom shows you the things that can happen. The red silicone sleeve is on the wrong side. The tubing is badly inserted in the silicone sleeve. See how it's like crooked? And there's like a gap here, like makes a gap. This silicone sleeve badly inserted on the barb connector. See how it's not fully flush there where the arrow is pointing, and it's bent. This could cause like a hard time in the breath flow. Won't flow through the tube.
For SDX documentation, we have setup notes for all of our patients that come. So in this setup note, you're going to include the SDX in the description of the treatment site. For example, if it was the left breast, you'd say left breast with SDX at the top of your setup note. You would describe where the SDX is positioned for the patient as well, like above the SDX or in between the poles on the wing board. On that setup note simulation, there are boxes that we check for dosimetry that tells them other scans that we have done for that simulation on that patient. So you're going to make sure that you check DIVH and SDX in those boxes so dosimetry knows that you did do an SDX scan. You're going to also check that there's free breathing, that you did a free breathing scan, and you do want to also check that you did a contra scan. The therapist will enter the SDX coaching results in that encounter as well. There's a SDX coaching results tab. So you're going to put that gating level in. That's the number that you got after you took the percentage calculation from that average. You'll do the breath hold time. So you're going to say whether the patient can hold for the 30 seconds or the 25 seconds. Then you're going to always enter that gating level and that stability zone level. Again, those 2 numbers never change. They are from the vendor. So the gating level is always 0.1 liters and the stability zone is always 0.14 liters. During the therapist's initial chart check, the therapist will enter a gating alert. So this will pop up on the treatment console when the patient first comes for treatment. You want to make sure that you put the gating level in there and the breath hold time that they can hold their breath. Then this is where you would also check to make sure that it pulls up correctly in the system. SDX breath hold needs to be indicated also by a physician. They put this in their treatment instructions and they also put it in their EBRT. The benefits of SDX, it enhances the tumor imaging and visualization, reduces the motion of the tumor during imaging and treatment. The SDX reduces treatment margin, so you're able to treat more a higher dose to just the tumor and reduce the dose to other vital organs. This is why it's super helpful for in an area where internal organs move around the diaphragm. You can reposition vital organs. So the patient, this is why it's also important that the patients take the deepest breath in that they can, because it kind of brings everything up and stabilizes it more. And it keeps it in the same spot every day when they come for treatment. It is highly effective for breast patients to get the heart out of the way, and it also reduces the lung dose.
Okay, so this shutdown process of the SDX is very important. You have to save the patient's file, of course, before unplugging the computer from the network. You would then close out the SDX software with the home button. It'll ask you to save. And then following the proper shutdown procedure allows time for the information to be written back into the database. It is possible for the device to become corrupt if you unplug it before saving and closing the software. So that's why it's important to follow the appropriate shutdown, because the SDX patients will not be, if you follow it, they will not be deleted from the system. That's real important. So if they are deleted from the system, like if the file becomes corrupt, you have to manually enter their information. So to do this, it's like starting from scratch, basically, like on the patient's training day, but you kind of have to trick the machine because you already have the patient's baseline level, written in a chart, how many minutes they can hold their breath for. So if it's deleted, you open the file, open patient file, like you're doing a new patient. You have to type in the patient's last name, first name, date of birth, and of course the ID. So then you check off each box again, it's like starting from scratch. Press the save button below the patient ID. Then you kind of have to go into preparation, the tab, because you're like basically starting over. But now you have to trick the machine into thinking that you're doing breath hold cycles. So you can actually use the QA syringe to do this. And this allows you to be able to log the breath hold level that is noted in the encounter or wherever you documented it. So like I said, you have to go through one breath hold cycle with the QA syringe. The SDX computer will not now allow you to enter the breath hold level. So you don't have to go through the 3 cycles. You can enter the patient's final level that you got by adding them all 3 together, dividing by the 3, and then timesing it by the 0.85 or the 0.75, whatever percentage you set. For breasts, we do 0.85. For everything else, it's 0.75, so 75%. That is noted in the documents. After you type in the breath hold level, you can go home and then save it. But then you kind of have to go back into the imaging tab, because remember, under the imaging tab, you did the whole training process. You trained the patients what to do, made sure they could do it. So you just have to click in the imaging tab. You don't have to actually do anything in it. And then you go home, of course, and then exit and save. So this will automatically put you into the treatment tab. So now you can just get started with the patient's treatment, filming process, and the whole 9 yards. So then you can exit and save it. So thank you for listening to our presentation. will now be taking questions and answering them for you.
Thank you very much, Laura. Thank you, Alaina. It was a great presentation. We do have a lot of questions in the chat and in the Q&A. So if that's okay, I'm going to read them and give you some time to answer. So can a patient be on oxygen during SDX use?
We have had times where patients have oxygen on a daily basis, and those are those candidates that usually don't work out well with the SDX because they already have lung issues and breathing issues that they need extra oxygen for. We do always try, but I would say 9 times out of 10 patients on oxygen do not pass SDX. They aren't able to really hold their breath long or get those nice deep breath inhales and exhales.
Okay. Do you have any video to show the SDX in action? I can actually answer that. We do have some videos on our YouTube channel, and I will share the link at the end. All right. Do you treat the breast cases, including supraclavicle nodal area? If so, how do you control the chin head position to reproduce the same position if the patient needs to look at the SDX device? Is the device indexed onto the couch?
We do use them for patients that you're treating their nodes. For Penn, the patient gets a baclock bag for their head and their arms, and you'll turn their head to the opposite side of the affected breast. So if you are doing a left breast, the patient's head is going to be turned to the right. And the gooseneck of the SDX, to use this thank you picture, that can bend and turn. So it actually can turn it to the right, and it will have the patient turn their head to the right with it and brings their chin up actually a lot nicer. Yeah. So you still do get that clearance. It actually helps with keeping the patient's head and neck and chin up. Yes, easier.
Okay, great. We do have a question from Crystal that's asking, can you elaborate more on why the calibration 20 minutes portion is performed monthly rather than daily, along with the calibration check that's 5 minutes?
Physics will do them monthly if on that day if they detect if there's a problem with the actual machine or it's not working or they fix something on it just to do an extra check. And then we do the daily QA part.
Yes, that's established from our physics department of what calibrations and QAs that we're responsible to do. So the daily QA defaults to just that 5 minute.
Mm-hmm. Yes, so we do have more questions on the Q&A. What is the rationale for using a higher breath hold, 85% instead of 75%, for breast compared to other sites? Is it because cardiac sparing is regarded as a higher priority than OAR sparing in other sites?
Yeah, so those percentages were given to us from physics, but it is, since the heart is right at the left, for the left breast, you want to minimize that dose as much as possible. So that's why they calc it to that 85% to get it even more out of the way.
About the parameters for the stability zone, did you decide to not adjust them?
Physics just told us that those are the values that are given from the vendors, and so we've never adjusted them. This is just a standard that's always in place. The stability, so if you did adjust the stability zone and you made it bigger, this would give the patient more leeway in how they exhale and inhale. So you don't want a huge stability zone. You want that smaller stability zone to keep everything more tight and in line.
Yes. So if I can add something to that, studies were made by the physicist that designed the SDX 20 years ago. And so he came up with a 85% because it was the best ratio between keeping the patient comfortable, but then having all of the anatomical advantages of doing the breath hold. So if Finn, if you want more information, I'm sure we can put you in contact with a physicist at Penn. Perhaps they will have more information. Next question is, do you know if there is a reference or a source of the minute, so I think 25 seconds requirement for the breath hold? Inova currently uses 20 seconds. Do you think it's too low? What's your experience as a therapist for that?
I would say when the less time that they hold their breath just increases the amount of times that they're going to have to actually hold their breath. And then increasing the amount of times that they have to hold their breath will increase the time that they're on the table. So the longer that they can hold the patient, it is ideal, or the longer the patient is able to hold their breath is ideal. You're able to get through more of their treatment beams, which will decrease their time on the table. I do find that a lot of times patients start to get tired if they're on there too long. The nose clip isn't very comfortable. The treatment position isn't always the best. The mouthpiece to keep that tight seal gets hard. Their mouths get dry. So you do want to make, I don't want to say as fast as possible, but you don't want to delay their time on the table any more than it needs to be.
Got it. Next question is, what is the advantage of using the inverted countdown feature during treatment? Do you instruct the patient to release their breath hold once the timer reaches 0, even if they're still within the window?
There is no advantage. The patient can, most patients stop at the 30 seconds just because they can't really hold their breath longer. So they do exhale. I think that's just a good standard set so that you're not causing patients to hold their breath longer than they really can, and like kind of fatiguing them. So it's an easier way to just say like a hard kind of cutoff. I will say that we do have patients who can hold their breath longer. And once, most times you're seeing that patient over and over again. So you establish a relationship. You know what patients become better at SDX, what patients can hold their breath longer. They talk to you, they tell you, hey, just so you know, I could hold past that 30 seconds. And that's nice to have that open communication because then you can keep the radiation beam on longer, and then you just, when they're exhale, you stop the radiation, you turned it off, let them breathe normal, catch their breath, and do it again.
Yeah, some of them want to hold more to get their treatment done faster.
I see. Okay, next question is, do you have a setup to allow the use of SDX for patients that use a head and neck couch when there may not be enough flat surface to position the SDX on the table?
We don't do SDX on any like a head and neck treatment. The only one that we use SDX for are the lymphomas, and they get put on the 5-point board. Our 5-point board does have has a part of the board where before the mask starts to connect that the device fits nicely on.
Yeah. And we just open up the face of the mask.
Got it. Is it a CIFCO board or QFix?
QFix?
Yeah, it's the 5-point from QFix. Got it. Do you ever use breath hold for proton breast patients? And if so, in what situation?
We have used SDX for proton breast patients. That is more of a doctor question. I'm not sure why they would use it versus not use it for patients. It's not very often that we've used it for proton breast patients, but it has. I don't know what triggers that to use the SDX.
Got it. Do you encounter the situation where the SDX system shows that the breath hold level is within the window? However, imaging shows that the diaphragm is off, perhaps due to a change in the patient breathing since the SIM?
I would say yes, that has happened. And usually if that happens, we call the physician over to the machine to look. A lot of times they will ask for a CT eval scan to be performed, just so that the dosimetry and physics and the MD can kind of look at the eval scan for that day versus the simulation day.
Mm-hmm. All right. Right, so that was all the questions for today. I think we're going to give 5 more minutes to see if anyone else has a questions. So you can write them in the chat or in the Q&A, and we'll take some time to answer right now. I'm going also to write our contact in the chat, just to make sure that you can contact us if you have any questions. If you want to send an email to Laura or to Alaina, you can send me an email and I will do an introductory message. And yes, we will post the link to the video on our YouTube channel. I will send an email to everyone at the end with that link. Let me see if I can put it in the chat right now. Okay, I'm going to send the YouTube link right now. Perfect. We have another question. Can you use the VR without using the breathing attachment and use it with Vision RT?
I'm not sure. We don't use Vision RT here. I don't really know how that would be done.
Yes, from a vendor perspective, we can't connect the video glasses to another device at the moment. It was specifically made for the SDX. All right, just a few more minutes. If anyone has a questions, please feel free to write them in the chat. Laura and Alaina are still here with us. All right, I think we will conclude the presentation. Laura, Alaina, thank you very much for being with us today and sharing your experience.
Thank you.
Thank you.
Okay, everyone, have a great day.
Bye.
Bye.
Jesus.